This is the Bariatric Surgery Information Session for Vision 12. We'll start with our objectives. One is to define obesity and different types of treatments available. Two, provide overview of the weight loss surgeries performed at Hines VA and other VAs within the Vision. Three, review patient qualifications. Four, review move requirements and define compliance. Five, psychological and dietary evaluations. 6. Consultation and surgery planning. Obesity is a chronic medical condition in which excess body fat accumulates in the body and may eventually have an adverse effect on health. It's caused by genetics, metabolism, eating and exercise habits, environment, and psychological factors. Treatments for weight loss. Treatments for weight loss start with diet and exercise. There are also structured weight loss programs that involve behavioral modification. Some patients qualify for medication management, while others may decide to pursue weight loss surgery. Surgery helps people achieve a larger amount of weight loss and has more durable results than the other options. What is body mass index, or BMI? BMI is a weight-to-height ratio and can be used to compare individuals' weights to healthy or normal weight ranges. Patients with a BMI under 20 are considered underweight. Those with a BMI that ranges 20 to 25 are normal weight. Patients with a BMI of 25 to 30 are overweight and can be addressed by lifestyle modifications. Patients with a BMI of 30 to 35 are considered to have class 1 obesity. These individuals can be treated with medications or surgery if there is an obesity-related medical problem. Those with a BMI that ranges 35 to 40 are considered to have class 2 obesity and are also candidates for medications or surgery. Those with a BMI greater than 40 are considered to have class 3 obesity and are also candidates for medications or surgery. Some of you may be asking, why should I have surgery when I can take a medication instead? There are multiple reasons why surgery can be better than medications for some patients. Weight loss with surgery is generally greater than patients achieve with medications alone. The average weight loss following bariatric surgery is 28.3% of a patient's body weight. This is in comparison to 10.3% of a patient's body weight when taking GLP-1 medications. GLP-1 medications include Ozempic, Wegovy, semaglutide, tirzepatide, Zepbound, and a number of other medications. The chart above demonstrates the weight loss over time, where you can see the patients that have the bariatric surgery lose and maintain more weight loss than those on GLP-1 medications. Bariatric surgery patients also go to the emergency department less, have fewer outpatient physician visits, and were hospitalized less often due to their improved weight and overall improvement in their medical-related comorbidities. In addition to being superior in terms of weight loss, bariatric surgery is also cheaper than medications. It costs an average of $11,700 less over the first 2 years of medication use compared to surgery. This difference in cost will increase over time as the medications for weight loss need to be maintained long-term. In fact, after stopping GLP-1 medications, patients regain an average of 68% of the weight they lost within 12 months of stopping. 85% of patients gain at least 50% of the weight they lost within 12 months of stopping medications. Just a tool. Bariatric surgery and medications are not a cure for obesity. They're a tool to help you in your weight loss journey. Weight loss surgery will not make you skinny, and most patients will not achieve a normal BMI. Weight loss surgery will help you lose a significant portion of weight and improve your overall health. Weight loss occurs over the entire body. You may not lose weight specifically where you want. Improved diet and increased activity are still required for long-term success. You must adhere to a new eating and drinking style in order for weight loss surgery to work for you. Weight loss procedures at Hines. There are many procedures for weight loss. The most commonly performed are 1. Sleeve gastrectomy, 2. Roux-en-Y gastric bypass, and 3. SADS. The SADS is also known as the single anastomosis duodenal with sleeve gastrectomy. 99% of bariatric surgeries are completed robotically. At some institutions, they are primarily completed laparoscopically. Laparoscopic and robotic surgery both are completed with small incisions, making the recovery much easier. What is excess body weight? Excess body weight is the weight a patient has above what is considered a normal body mass index. The average weight loss with bariatric surgery is 50 to 80% of excess body weight. The sleeve gastrectomy is the most commonly performed bariatric procedure across the world. With the sleeve gastrectomy, a stapling device is used to remove the majority of the stomach. Restriction is created by permanently removing approximately 85% of the stomach along the greater curvature. The advantages of the sleeve gastrectomy are it is less technically demanding, with lower short-term risk of complications and faster recovery time. The average weight loss with sleeve gastrectomy is 50 to 55% of excess body weight. This weight loss occurs over 1 to 1.5 years. It is notable that the sleeve gastrectomy offers slightly less weight loss than the other bariatric procedures. The sleeve gastrectomy causes favorable changes in gut hormones that suppress hunger, reduce appetite, improve satiety, improve blood sugar, and encourage weight loss. Some examples of these hormones that are affected are ghrelin and GLP-1. Many patients will have improvement or resolution of type 2 diabetes. They also experience reduction in blood pressure, cholesterol levels, relief of sleep apnea, and other improvements in medical problems related to obesity. There are fewer vitamin and mineral deficiencies with sleeve gastrectomy when compared to gastric bypass and the SADS procedures. There are risks associated with the sleeve gastrectomy. Some of these risks include staple line leak, which occurs less than 0.3% of the time, narrowing or stricture of the sleeve, which occurs less than 0.5% of the time. There are long-term risks including chronic reflux, which occurs in about 1 in 3 patients, as well as long-term weight regain or inadequate weight loss, which occurs in 15 to 20% of people. There are short-term risks with all bariatric procedures that are related to overall health. These include things like heart attack, blood clot, and stroke. You will be evaluated by your physician to make sure you are very low risk for these things before proceeding with surgery. The Roux-en-Y gastric bypass is the second most commonly performed bariatric procedure. This is commonly referred to as the gastric bypass. In a gastric bypass, more than 75% of the stomach is bypassed, and a small portion of the stomach remains functional. The small intestine is then brought up and connected to this top small gastric pouch. The small intestine is then reconnected to itself to allow the digestive enzymes to mix with the food that is consumed. This is a limited intestinal bypass that contributes additional weight loss over the sleeve gastrectomy and has further effects on hunger control. There is no malabsorption of protein with the standard gastric bypass, but there is a need to increase vitamin and iron intake. With the gastric bypass, restriction is created by dividing the stomach, making the new pouch about the size of a golf ball. There is some limited malabsorption that occurs by dividing the jejunum, which is the second portion of the small intestine, and reconnecting this to the gastric pouch. This reduces the amount of calories and nutrients that are absorbed. The rerouting produces changes in gut hormones that promote satiety and reverse one of the mechanisms of type 2 diabetes. The gastric bypass offers 60 to 70% excess body weight loss. It also has improved resolution of type 2 diabetes, sleep apnea, high cholesterol, non-alcoholic steatohepatitis or NASH, hypertension, venous stasis disease, stress urinary incontinence, peripheral edema, polycystic ovary syndrome, and gastroesophageal reflux disease. Like the sleeve gastrectomy, the gastric bypass also has risks. The risks include leak at the new connections, which similarly occurs less than 0.3% of the time, a blockage at one of the connections, which has a 5% lifetime risk, short-term risks similar to what we discussed with medical complications related to the sleeve gastrectomy. There are also surgical risks including bleeding, infection, and wound problems. Long-term, with the gastric bypass, there's a risk of ulcers at the connection between the stomach and the small intestine. This lifetime risk is about 3 to 4%. After the gastric bypass procedure, in order to decrease this risk, patients are not allowed to take NSAID medications. These include ibuprofen, naproxen, aspirin, and Aleve. Patients also are not allowed to use nicotine, as both of these things will increase the risk of ulcers. There is overall a low risk of vitamin deficiency. However, it is higher with the gastric bypass than with the sleeve gastrectomy. There's also something called dumping syndrome that can occur after both the gastric bypass and the SADI procedure. This can be avoided by following dietary recommendations closely. The final procedure we'll discuss is the SADI-S, or single anastomosis duodenal ileostomy with sleeve gastrectomy. This procedure consists of performing a sleeve gastrectomy, exactly how we previously discussed. There is then an intestinal bypass that is added to increase the weight loss and comorbidity resolution rates. This procedure is performed by dividing the first portion of the small intestine and connecting the later part of the small intestine to that first portion. This allows the majority of the food to bypass the small intestine, limiting how much calories, fat, and carbohydrates that can be absorbed from the food consumed. The SADS offers all of the benefits of the sleeve gastrectomy. There is more malabsorption with the SADS than with the gastric bypass. This results in the greatest weight loss of any of the bariatric procedures. The rerouting produces changes in gut hormones, just like the gastric bypass. The SADS has the advantage of offering 70 to 80% excess body weight loss, as well as improvement in the previously discussed medical problems related to obesity. The SADS is typically reserved for those with a BMI greater than 50 or those with prior sleeve gastrectomy looking for additional weight loss. Just like the other procedures, there are risks involved with the SADI. There is a less than 1% risk of leak at the new connections or from the sleeve. There's a less than 5% lifetime risk of blockage of the stomach or small intestine. There are short-term risks associated with your general health. Like the gastric bypass, there is also a risk of dumping syndrome and anastomotic ulcers. However, these risks are lower with the SADS than with the gastric bypass. The SADS also has a risk of vitamin deficiency that is equivalent to that you have with the gastric bypass. We will now compare these operations side by side. In this comparison, we're using a hypothetical patient that weighed 300 pounds. We'll first look at total body weight loss. With a gastric sleeve, the average total body weight loss is about 30%, which would result in 87-pound weight loss. If the patient had a gastric bypass, they would lose 34% of their total body weight and expect to lose about 102 pounds. With the SADS operation, the weight loss is superior with 40% total body weight loss or a long-term weight loss of 120 pounds. It is important to note that these numbers are averages and patients will not all experience the same degree of weight loss. Some will have greater weight loss than is stated here and others will lose less. The overall risk of dying after one of these operations is very low, with an overall operative mortality rate of 0.03% with a sleeve gastrectomy, 0.06% with a gastric bypass, and 0.1% with the SADS. These procedures also offer improvement or resolution of diabetes. With the SADS, the diabetes resolution rate is the highest, and it's the lowest with the gastric sleeve. This chart demonstrates the average expected weight loss within 12 months of surgery. The sleeve gastrectomy has the lowest weight loss and it can be seen on the red line, with the gastric bypass on the blue line, and the SADS with the most weight loss on the orange line. On one of the earlier slides, we discussed the risk of dying after bariatric surgery. That risk is very low. In fact, most patients live significantly longer after having bariatric surgery. The average life expectancy is actually 3 years longer for patients who have bariatric surgery than those who don't. This is because after surgery, you will lose a significant amount of weight, improve your medical problems, and be healthier overall. When should bariatric surgery be considered? Patients who have unsuccessful attempts at weight loss through other methods, including calorie restriction, increased exercise, and or medical weight loss, could be considered for surgery. Patients must be committed to making permanent lifestyle changes in order to ensure that they have continued success. This includes following a specific diet for the rest of your life, exercising regularly, and following up with your healthcare providers routinely. Patients that are motivated and willing to accept the risks of bariatric surgery do excellent after the procedures. The patient's primary care provider and other physicians are important team members to collaborate with and should support your choice to move forward with surgery. It is also important that patients are motivated and well-informed in order to have the best outcomes after procedures. After bariatric surgery, most patients spend 1 to 2 nights in the hospital. You must have someone to drive you to the hospital and pick you up and take you home. Prior to bariatric surgery, patients are required to do a liquid diet with pre-surgery drinks that will be supplied by the VA. After surgery, 1 month supply of high-protein powder will be given in order to ensure you're meeting your protein goals. There are also bariatric vitamins and minerals that will be supplied through the VA. If you are interested in pursuing bariatric surgery, you'll meet with the surgeon to discuss the options that are appropriate for you, as well as the risks and benefits of surgery. While you're moving through the program, you will continue to work with the MOVE team to work on nutritional and lifestyle changes. Prior to the surgery, you'll meet one-on-one with a dietitian and psychologist for assessments and education in order to prepare for the procedure.